Hello, I'm Dr. George Lundberg, editor-at-large for MedPage Today, and we are in Chicago for the annual meeting of the American Medical Association. And right now, we're going to be visiting with Dr. Fred Ralston, a practicing internist from Fayetteville, Tennessee, who's agreed to talk to us about whatever we want to talk about, but primarily the American College of Physicians, of which he is now the president. Welcome.
Glad to be here.
We really do appreciate your coming to talk with us, and there's a lot to talk about. Let's start with your organization. How long have you been president?
Became president in Toronto in April and will serve a one-year term, and am very excited about all the things we'll be doing this year.
So you're 2 months into it.
2 months into it.
You doing okay?
Yeah. It's an interesting balance of time, but I love what I do in my practice. But the important thing is the work for the American College of Physicians, I think, is going to be good for my practice and my patients ultimately.
Now, Fayetteville is in southern Tennessee, close to the Alabama border?
Right. We're about 30 miles north of Huntsville, Alabama, and 80 miles south of Nashville.
So does your patient population come from Alabama as well as from Tennessee?
A small number of patients come from Alabama. Many patients work in Alabama but live in Fayetteville.
Yeah, the reason for this question is I'm from Alabama. Even though I may not sound like it, you do sound a bit like you, even though you went to Yale, the college, you probably grew up in Tennessee.
Yes.
Okay, the American College of Physicians, when it merged with the American Society for Internal Medicine, became a much larger organization. What is its current membership?
Well, we have 129,000 members, and roughly half subspecialists and half general internists.
Well, does that make you the #2 membership medical association in America or the #1 membership medical association?
We like to say that we're the largest medical specialty society in the country.
So you won't take the bait on what the AMA membership is, which I find, as an AMA membership, to be a bit fuzzy.
We've got a lot of great stuff that we can talk about today.
There's a lot going on with the American Medical Association, but congratulations on the merger. The success of the merger, obviously, I presume you pronounce it a success.
It's been, to me, one of the most successful mergers that I can recall.
Well, I think that's just great. And of course you had to have a Washington presence as well as a Philadelphia presence, and you've maintained that and expanded that.
That's true.
Okay, health system reform. Your organization's been for some such thing to get insurance for everybody for a long time.
Right.
So where are you now as an organization with what's been passed?
Well, one of the main reasons that we gave what we called our qualified support, because nobody can agree on every element of a policy, much less a complex piece of legislation. But the area that excited us the most was that at the end of the day, we feel about 95% of Americans will have access to affordable insurance. And we also feared that if that particular initiative failed, that it might be another 10 to 15 years before that came up on the political radar screen, and we just don't feel that we could have afforded to wait to do that.
So your organizational position is to work with what we have legislatively, do the best we can with the regulations, with implementation, to do what we all want to do, is cover everybody with decent basic medical care at a reasonable cost.
Right, and we had 4 elements that we really wanted to deal with in the legislation, and we were disappointed that the other 3 elements weren't dealt with as effectively. And I think the second one, looking at really the specialty mix that we have in the United States, just for whatever reason, we've melded toward a 70-30 roughly mix between other specialties in primary care. And we feel that a move toward more of a 50-50 mix would be good for patients and really good for the country as a whole. And if you look at rebalancing the medical portfolio, if you will, we're going to have to really change some career plans among medical students to move anywhere near that 50% level.
Well, it's been going the other way for a long time for a whole lot of reasons, which are powerful drivers. And in order to turn that around, it's like taking a big ship in the Atlantic and trying to turn it around. It's slow. Do you really think you're going to be able to do that? Of course we should.
Well, we have to. I think if we all look at the May special issue of Health Affairs on primary care, I believe they make a number of statements to the effect that without a sharp move toward more primary care, effectively delivered, there's virtually no way that we'll ever bend the cost curve.
Well, I certainly agree with that. Now, talking about the cost curve, it's been on its way up as long as I've watched it, which is a long time. And to even flatten its curve and bend it back down, critically important to do. What is your organization prepared to do? What kind of steps to try to begin that process for real?
Well, I think that, and that really would have been the third area that I would have mentioned that we didn't think that the legislation worked on. And we really think that we need to align the incentives on our healthcare payment and delivery system where the patients, doctors, insurers, ultimately government, taxpayers, all have a system that works to get the right outcome. And right now, I look at it like an assembly line where people are paid for messing with the raw materials and the product on the assembly line, and there's no real true judgment. There are attempts to measure quality and report quality, but there's no real attempt to look at the finished product and to pay people for things except for the procedures or the activity. In primary care, I've seen it estimated that roughly half of what I do is outside of an office visit, yet I'm only paid for face-to-face encounter with patients.
So money matters a lot. Well, I'm going to speak to you, but I'm also going to speak to our audience about two specific things because I want the audience to know about this and then get your reaction as well. Last December in the New England Journal of Medicine, Professor Howard Brody from the University of Texas Medical Branch in Galveston, a very well-known physician ethicist, laid on the specialty societies of the United States of America the requirement to start looking at costs big time. And he said that the specialty societies should list the top 5 diagnostic tests or treatment commonly ordered by their members that are among the most expensive services provided and try to figure out a way to bring them under control. That was added to by Deborah Grady and Rita Redberg in the Archives of Internal Medicine just a couple of months ago, who said less is more. Let's stop doing this stuff that doesn't work as well as it should and do simpler things. Quickly, how do you react to that?
Well, we really need to sign you up to do some promotions for our high-value, cost-conscious initiative that we're beginning in the fall. We're gonna roll out some articles. Steve Weinberger is our point person on that, and I believe we're going to start with low back pain.
Okay, and I'm going to take on that and say thank you very much for that. Thank you for being candid about a variety of things on low back pain, which you brought up. I'd like to refer our listeners and viewers to Stabbed in the Back by Norton Hadler, which explains very nicely to doctors and others what's been going on with back pain. A final word?
We really feel like many of these different elements that we'd like to move toward are in the patient-centered medical home. And we just think that's a wonderful opportunity to arrange care in a patient-friendly manner. Once again, in that health affairs issue, they gave some initial results out of the group health cooperative that showed after their initial data came in, patients were happier, doctors were happier, and it appeared to be at lower cost. But I love to hear from internists that they had canceled their plans to retire because it was fun practicing medicine again. That's what we're hoping for in the patient-centered medical home.
I love that, and I hope we can have another conversation for MedPage Today at a later date on a related topic. And thank you for joining us today. We've been talking with the president of the American College of Physicians, who has said what I think are some pretty refreshing things.